Good afternoon, everyone. We'll get started here in just a moment. And Rachel, I'm still waiting for one or two more members to join, but it looks like people are still joining at the moment. And again, as a reminder, if you are a committee member, if you would put your name in the chat so we can capture the correct attendance for our committee members. Doesn't look like anyone is on the phone yet. Maybe just give it another minute or so for a couple more to join, Rachel. Thanks.
Sounds good. Thank you.
Okay, looks like off of my recount, looks like we are good to go. We've got a quorum, Rachel, if you want to take it away. Thank you.
Awesome. Thank you so much, Sharon. Welcome everyone to the September, sorry, I'm skipping ahead. September MAC meeting. This is my first meeting running as chair, so please bear with me if I do anything wrong. My apologies. I think our first order of business right now is to approve the minutes for August 15th, 2024 meeting. So I will take any motions to approve those minutes or anything else, any edits. Anyone?
I'll motion to approve them, Rachel.
Thank you. Can I get anyone want to second that motion to approve the minutes?
This is Michael. I will approve or second the motion.
Thank you so much, Michael. So that is approved. And then I think our next order of business is to welcome our new member at large, Carlos Flores. Carlos, do you want to reintroduce yourself? I know you've been a member of the MAC, but I don't know if you want to reintroduce yourself as the member at large.
Yeah, very nice. Hi, everybody. My name is Carlos Flores. I work at Holy Cross Ministries, and it's nice to see everybody. And thanks for asking me to be the new member at large. I appreciate it.
Thank you for being willing to serve. Again, thank you to Michael and the previous executive committee. We really appreciate your work and your help transitioning us into this new executive committee. And again, thank you to Carlos for your willingness to serve. So our next agenda item is balance billing. And so I'll pass that off to Greg Trollin, who I believe is on here. Yes.
Yes, I am. Thank you, Rachel. Hi, I'm Greg Trollin. I am the Office Director for Managed Healthcare in the Division of Integrated Healthcare, Medicaid and CHIP, to make it short. Anyway, one of the things that we discussed at the last MAC meeting was balance billing, and so we wanted to do a little follow-up related to that particular topic. Specifically, we wanted to talk through a couple key things that are important related to and for members when they actually receive something that indicates that they have a bill from a provider or they believe that they've been balance billed. So for starters, let's see here, I'm going to just put I'm going to be putting a few things into the chat so people can look at those, but also grab them if they want. So these are a couple key things to remember for essentially taking a concern and bringing it forward to various channels for problem solving and solutions. And so a couple key things for members is for the member to contact a provider and get the information related to data service, the amount that's being billed, and the reason why the provider is sending them a bill. So some of that information is going to be important when the member is going to outreach to other individuals for assistance in getting some problems solved related to balance billing. So once that information is obtained by the member, then there's two key pathways to start the problem solving process. The first one is if the member's enrolled with a managed care entity. So this could be an accountable care organization. It might be a prepaid mental health plan. Maybe it's a dental plan. They want to reach out to their managed care entity to inform them of this particular issue and have the managed care entity assist with the balance billing. If the member is a fee-for-service network, which means they're not enrolled with a managed care plan, then they would want to contact our HPR line, which is our health program representatives, and or they could follow up, or they could contact our constituent services number. I'm going to put that information directly into the chat. So you'll see our HPR line right there, as well as constituent services. Just so you know, our HPR line is kind of like our call center for members to outreach to Medicaid and CHIP when they have issues, along with a whole variety of other things that they may have questions about, whether it's benefits, getting enrolled with plan, things like that. But they can reach out to our HPRs to discuss issues related to balance billing. We have a number of HPRs, as you know, in our constituent services area. We have Tracy Barkley, who's does a wonderful job of trying to manage things as a solo entity. So our first line of outreach would be to our HPRs, and then sometimes we triage with Tracy, depending on the circumstances. But it doesn't mean that people who maybe in the past have worked directly with Tracy and have an issue, they can certainly reach out to our constituent services. Let's see. So those are just some key contacts. Another thing we wanted to do is we've been working on some communication, specifically some videos that we are producing. One is a video on balance billing that's more specific for providers, so that providers understand how billing works in Medicaid. Again, right, Medicaid is different from commercial insurance, can be different from Medicare. And as a result of that, sometimes individuals at providers and provider offices, right, are confused just by the myriad of hoops and steps that have to be undertaken in order to submit claims or get things paid. Sometimes not realizing that Medicaid operates with some specific important guidelines around what can or cannot be billed to a Medicaid member. And so sometimes they're not necessarily aware of it. So one of the things we've done is we produced a provider video. And what I'm going to do is we're not going to show this particular video in the MAC today, but we are going to show our other video. But I'm going to grab the link for the provider video, drop that into the chat. This is available on our website currently. And actually, if you go into the video, there's good information that's valuable even on the member side, because it informs and will help educate members about what maybe a provider should or should not be doing. Like if they get a bill from a provider, this video can be educational in the sense, well, I shouldn't have gotten a bill at all for any of these services. So, you know, it's actually useful information, not only for providers themselves, but also for members, as well as stakeholders and advocates and other people who are assisting members when they do end up in a situation where they have a bill from a provider. Stephanie, you have a question?
Yeah, I do. Thanks, Greg. Thank you for this information. I guess kind of have like a two-part question. And so my first is, so if I understand correctly, with like the information that you're asking the members to collect and then to provide that to their health plan, is there a reason why a copy of the bill would not be sufficient?
No. If the copy of the bill that they received and it actually has all of that information on it, then I think that is sufficient, right? They wouldn't have to outreach to the provider.
Okay.
And
Cool.
I think,
Oh, go ahead.
oh, I was just going to say, like, sometimes for example, number 3, the reason why the provider's sending them a bill, some of that might be a lot more difficult to understand. So maybe some clarity about why am I getting this bill, if it's not clear. The other thing is if there is some reason that's been included on a statement or a bill that they've received, then a member could just reach out to an HPR and say, I received this I received this correspondence from my provider saying I owe money. And then an HPR can help sort of walk through what's in there, and maybe answer some questions, and then provide some guidance on how they might follow up.
Okay. Thank you. I guess so I think that is actually going to be a really hard part for members to get. So I think that if the plans, I don't know if they were a part of how you kind of came up with that list, but I think that's on the plans. They need to call the provider and figure, they have to work that out together, right? That's not something
Sure.
I mean, that I've gone through that. It's a very complicated experience. And I don't think that that's something, that members are going to be able to successfully navigate, because it ends up becoming language and jargon that then they have to call.
Right.
Very frustrating. They will give up. So I guess hopefully a bill is ideally a bill would be sufficient, and that the plans need to kind of take it from there and work it out with the provider. Seems like that would be
That's a better
responsibility on the
approach
people
and
that are being
strategy. Yeah.
paid.
And I guess one of the things is I think Tracy sort of was sort of helping construct this information about what might be helpful. And maybe those are some of the things that Tracy has run into. But I think to your point, if the member's enrolled with a health plan, then the health plan should help them navigate these particular situations.
Yeah, absolutely. And I love that you guys did a video. Are y'all going to be putting that on social media, or I know that whenever you Google, when people just Google I have a bill, I'm on Medicaid, I have a bill, I wasn't expecting it, or just those types of words. I don't know if there's a way to make sure that gets up to the top, and just having that, I don't know how all that internet stuff works, but I think there's some way to make sure that that page gets to the top, I guess, of the Google searches. And then also just if there's any way that we can start to have an understanding of how often this is happening. I don't know what that process is but if you all are having conversations about trying to understand how often this is happening, I think that that's something that's really important in the, especially because it is against the patient, the member rights for them to be balance billed. And so I hope that is some real understanding that figuring out how often it's happening and addressing any kind of systemic problems. I know that we talked about this last month as well, but just wanted to say that I hope there is some kind of data collection going on that we can understand how often this is going on.
Yeah, thanks, Stephanie. And Brian, I don't know if you have anything to the first part of Stephanie's, or maybe the middle part of Stephanie's question, just around a distribution or sort of viewership related to the upcoming member video specifically.
Yeah, thank you. It is a good question, and we would love feedback from MAC members like yourself of what you would suggest. I definitely understand what you're saying about making it appear prominent in search terms for our website. We're asking our PIO officer as well for suggestions. We've tossed around the idea of social media distribution, or maybe leveraging email addresses that we do have on file. But again, we would welcome your feedback and recommendations beyond what you already shared, which is good recommendations.
Okay. Yeah, thanks, Brian. So what we're going to do is Sharon is going to, hopefully without any technical difficulties, share the member video that we've put together. Now, this video hasn't been distributed yet, hasn't been made, or, you know, it's not external facing at this point. So what we'd like to do is show this video. Any immediate feedback that the MAC has related to it would be totally welcome. But then in addition to that, any follow-up feedback that, you know, people think about after we actually do the video and our meeting is over, you guys can certainly send that to Sharon, and we can capture that, gather it up, and bring it forward for consideration.
Hey, thank you. If I could get I'm going to push play. If I can get a thumbs up from somebody, if you guys can hear this. Thanks.
Video titled, Receiving Medical Bills When You Have Medicaid. Getting swamped with bills is very frustrating, especially with money being tight. As a Medicaid member, it is important to understand your Medicaid rights and responsibilities with medical bills. This video discusses steps to take when receiving a medical bill from your Medicaid provider. Receiving a bill from your provider when you have Medicaid is often referred to as balance billing. Topics for this video include: 1 is balance billing, referring to the Medicaid Member Guide. Steps to take when receiving a medical bill. Bills you may have to pay or have to pay. Copay information. Third-party liability in Medicaid. And retroactive coverage. What is balance billing? Balance billing occurs when a Medicaid provider bills you the difference between the amount they charge and the amount Medicaid approves. For example, if a provider charges $200 for a service and the Medicaid approved amount is $100, the provider is not allowed to balance bill you the remaining $100 of the covered service. Referring to the Medicaid Member Guide. Become familiar with the Utah Medicaid Member Guide. This guide helps to explain your Medicaid benefits, rights and responsibilities, copays, Medicaid card, managed care plans, well child exams. This guide can be found on the Utah Medicaid website. That URL is medicaid.utah.gov. Hover over the members menu and select Resources. Under Get Medicaid Education Materials, click Learn More. Under Covered Services, select a Medicaid Member Guide link either in English or Spanish. Steps to take when receiving a medical bill. The Medical Bills When You Have Medicaid section in the Member Guide has helpful information on what to do when you receive a medical bill. For example, if you receive a bill for medical care, you should call your provider's office and ask if they have billed Medicaid. If you still have problems with the bill, call a health program representative at 1-866-608-9422. Bills you may have to pay. You may have to pay the bill for a covered service if you have a plan and see a provider not in your plan. Receive services and do not show your Medicaid card, or break your appointment. Bills you have to pay. You will have to pay the bill for services when you are not eligible for Medicaid. After filing a hearing, the claim is denied. When you receive a non-covered service, if you choose to have services that Medicaid does not cover, sign a form before the service that documents the received services, including the frequency and duration. You understand that Medicaid will not pay for the service and the amount you have to pay for the service. Copayments. Refer to your Welcome to Medicaid letter for copay information. Before collecting a copayment, your provider should confirm that the service and member have a copayment requirement. Ask for a receipt for the collected copayment. You are responsible for keeping copayment receipts in case of delayed billings by providers or discrepancies. If a copayment is not collected at the time of service, the provider may bill you for the copay. Third-party liability in Medicaid. Medicaid is not the first payer of a medical bill when third-party liability, known as TPL, exists, such as other health insurance. Your provider should bill all responsible third parties first and then Medicaid last. Medicaid will not make an additional payment if the amount received from a third party is equal to or greater than the amount Medicaid would pay. In that case, the TPL payment is considered payment in full. Suppose your provider receives a third-party payment and does not bill Medicaid for the balance because they anticipate the Medicaid payment to be zero. In that case, the TPL payment is considered payment in full, and they should not bill you. For additional information, please refer to the Other Insurance or Medicare section of the member guide. Retroactive coverage. Most Medicaid programs allow you to request coverage for medical services for up to 3 months before the month you file a Medicaid application. If you receive medical, dental, or mental health services and subsequently become eligible for retroactive coverage, you may return to each provider with a Medicaid identification card for the month the service was provided. A provider who has already rendered services may subsequently choose to accept Medicaid as payment in full or refuse to seek Medicaid payment because the patient had not been determined eligible for Medicaid at the time of service. If the provider accepts Medicaid, Medicaid may pay for the service. If the provider refuses Medicaid, then you are responsible for the charges. Thank you for watching this video on receiving medical bills when you have Medicaid. For any problems or questions regarding medical bills, call a health program representative at 1-888-608-8422.
Okay. So that was the video. I just wanted to note, whoever's kind of taking the feedback, the last phone number that was just displayed for the health program representatives, it's not 888, but it's 866. So that would be one thing that needs to be fixed for the video.
Thank you for pointing that out. So I think I appreciate the amount of information that was put in that, and I think it's important information, but to me, some of that seems like maybe it should be provider. Like, I guess at the end of the day, I think the most important thing for a Medicaid member to know is if they receive a bill that they should be calling either the provider or probably, like Steph said, like a health program representative and passing that information on to them to look into it. I think that's really kind of the crux of it, and that information is kind of buried in the middle. So I would push that to get to the beginning. Everything else after that, I think when you go into all that detail, it's great if a Medicaid member wants to or has time to learn that, but I don't know if it's necessary that they know all of that policy. It really should be, in my opinion, I think probably, on a health program representative to be looking into it for them, because like Steph said, it's complicated. Even like, I mean, for me who knows some of this stuff, your eyes kind of glaze over a little like halfway through because it's just a ton of information at once, and it is pretty technical, like policy-based stuff. So that's my feedback, is push the part about if you get a bill, if you're a Medicaid member and you get a bill, push that to pretty much, like, I would say the first 30 seconds. Then Steph.
Yeah, thanks, Rachel.
Yeah. I appreciate like the effort. I just think maybe like the Disability Law Center and maybe like a small group of us can meet with some of you all at the department and just have like a separate conversation. I cannot follow that many steps. And I definitely wouldn't have been able to follow that many steps right after my accident. And I don't find that a lot of the people that I help, executive functioning is just a little bit hard. So I don't know. I just think maybe we can all have like a separate conversation. I'm sure there's like best practices around like how many steps are appropriate to give people in a way that's like accessible to different kinds of cognitive abilities. So, but I appreciate the effort, but maybe it would be better to have like a longer conversation with like a group of us that can kind of talk more in depth about that.
You betcha. Yep. Thanks, Stephanie.
Yeah, we do appreciate. I mean, this this is a first draft, and I'm also not aware whether any other Medicaid agencies across the nation have done it. That it's coming to mind that maybe we should search that out. But I mean, I think what the committee members have touched on is this is a very complicated topic, and I'm starting to think of like maybe breaking pieces out, even like 30-second blurbs or something. But yeah, we're just beginning to approach this and appreciate the feedback. So I think a separate conversation outside of this meeting would be good.
Great. Thanks, Brian. Any other feedback from committee members or the public? Brian, I'll also say that I like the idea of maybe breaking some of that up, because I think if someone does want to look into this on their own time, they can, but I think the general sense of it should be short and sweet, what to do if you receive a bill. But again, we can like talk about this later, but I think you're probably onto something with breaking it up into smaller segments, maybe in both a visual and like written format, I guess, kind of combined, but we can talk about that more.
Right.
Any other comments?
And again, thanks everybody for the feedback. And if you do have additional feedback, any thoughts, right, that you want to share, please just send those up to Sharon, and we'll make sure we'll gather up that information.
Awesome. Thank you so much, Greg. We appreciate the time and the
sure. Thank you.
I believe the next item on the agenda is it the OIG, the Office of the Inspector General Audit overview? Is that you, Brian? I think that's next.
I believe so, yes.
Well, then take it away.
Thank you. One moment. Okay. Great. Thank you. I was asked today to speak on the HHS OIG unwinding audit. A lot of times we just differentiate OIG when we're talking about, we have a state agency that's the OIG. The HHS OIG is the Federal Health and Human Services OIG that conducted this audit. Just a quick overview of the timeline. We were engaged in this audit beginning in October of 2023. We received the engagement letter, went through an audit entrance conference, multiple rounds of data requests. We facilitated 140 case reviews for OIG, and then came up with a final report on August 2024. So just to show for the group what a case review looked like, it was a very in-depth review of eligibility cases. Like I mentioned, it was for 140 individuals, but to be clear, they would review any and all data available for each of the 140 cases. So they sampled individuals that had eligibility renewed during the period, and individuals who had eligibility closed during the period. And just for clarification, the period was the beginning of unwinding up to, I believe, August of 2023. They even went as far as reviewing where we reported the member on our unwinding reports. So as we've shared with this audience throughout unwinding, we shared those unwinding reports, and that data ended up on our dashboard. So each of those numbers in aggregate represented a member. We shared where the member ended up in the report for OIG, and they made a determination on whether we reported them correctly. But a case review included all documents demonstrating their income and assets, their address, worker narration, anything necessary to make a determination on whether we made the correct action. And what OIG found was, of the 140 sampled cases, they found that 2 individuals did have their eligibility incorrectly closed. 4 had their eligibility incorrectly renewed. There were 9 deficiencies identified, which essentially means that some step along the process of eligibility renewal wasn't perfectly adhered to, but the ultimate eligibility decision was the correct one. So those were labeled as deficiencies. And then they did find that 15 individuals of the 140 were reported on an incorrect line. An example of that is if we reported them as renewed through eligibility form, but they were actually reviewed via ex parte, that would be the type of error because it was just a reporting error. And the full report is publicly accessible. I've linked it here. The whole, this whole slideshow will be distributed to the MAC committee later this afternoon. So some recommendations and our actions that we're agreeing to that come out of the unwinding audit. So recommendation number 1 is that for the 6 individuals that had an incorrect eligibility determination, we were advised to have a corrected eligibility determination. Yes, I think I can. Actually, probably I'll ask Michelle or Gina to post that in the chat for me.
Yeah, Brian.
Thank you, Michelle. So this is the 4 that were incorrectly renewed and 2 incorrectly closed. We proceeded with correcting that and offering them the opportunity to complete a corrected eligibility determination. Number 2 was to coordinate with DWS to provide periodic training to caseworkers that focus on verifying and documenting information used and steps performed during the eligibility renewal process. And they identified 3 topics for us. Number 1 was a topic to emphasizing verifying income and assets, verifying residency/contact information, and correctly executing case review and reporting. So I've summarized our response here. In the full report, you can see our lengthy response to this, but we are concurring to it and incorporating these topics into DWS training topics. Number 1, because January 2024 was after these eligibility decisions in the review period, we do mention that we published a case maintenance and processing refresher in January 2024 that did include income and asset determination topics. In August 2024, we completed a supervisory training that did include topics on verifying residency and contact information. And then coming soon, DWS is publishing a training on case narration that should go to the 3rd topic there. The 3rd of 4 recommendations from HHS OIG was that our department identify and correct the EREP data limitations, which in some cases prevented proper reporting classification. Again, I mentioned earlier about like a case reviewed by form that was actually renewed via ex parte. We were aware that this was going to be a complication going into unwinding in general. We did not have the ability to identify what cases were reviewed via ex parte, and we, as opposed to being reviewed by form, renewed that is. And so we kind of knew that that was going to be a complication, but we have, since this reporting period, built in some improvements. It includes the automated ex parte that we've talked about in this group before. So we are more able now to report on the individuals who were renewed via ex parte. So that is something that we agreed with HHS OIG, and we have already worked to improve that. And then finally, HHS OIG did recommend that we strengthen our policies and procedures to provide for greater accuracy in the monthly unwinding data reports and any future reports of a similar nature. And so what we are going to do as a result is develop an SOP with DWS to solidify our process and quality assurance for reporting. And we expect to have that finalized next month by the end of October. And so with that, I will open it up to any questions. And Rachel, if you want to lead, or anybody from the group want to ask questions, I'm happy to take them.
Yeah, I mean, I think we're a pretty civilized group here, so I appreciate it. If they have some questions, they can ask. But if anyone wants to raise their hand, I can also give you permission.
I do also just want to say that we were impressed by the knowledge and experience of our HHS OIG reviewers. They really did know eligibility policy. We respected their recommendations. As I said, we concurred with all four recommendations. And also, I just want to thank both our team and Medicaid and DWS. There was several hours over several days that went into assuring that the reviews were done accurately. And so I'm appreciative of that.
There is a question in the chat from Steph about when will the Office of Civil Rights, the OCR report be out. I know, Steph, what I had heard is that there's still no updates on that. Brian, I don't know if you all have heard anything since then.
That's correct. We heard from them, I believe it was about 2 months ago, and answered all of their questions at that point, but have not heard since that point. So we will continue to be responsive when we hear from them, but no new updates.
Any other questions or comments on the OIG audit? All right. Then thank you, Brian. I appreciate that. We all appreciate that. And then I think we can move on to Director Strohecker's presentation on the changes to the MAC without a C and the creation of the BAC, or with only one C, I should say.
Yeah, thank you. And you are right. It's the MAC with just one C now. So hello, everyone. Thank you for the opportunity to give an update and a proposal, actually, and an opportunity for you to review and weigh in on what is coming. So just a little bit of background. In a recently released rule, it was actually buried within our HCBS access rule, which is also titled Ensuring Access to Medicaid Programs. There were new requirements for our current MAC outlined in this rule. And what we would like to do today is really just review what some of these changes are. This is an introduction to some of the changes that were put forth in the rule, and also some changes that are being introduced to the bylaws. So they are changes of the CFR requirements as well as the bylaws that were outlined in the federal rule. What I'm going to go through today is what we are proposing. We have reviewed the entire rule, looked at it, and compared what we have today to what is required in the future final rule. And we would like to actually, from this presentation, go through this with you today. And then we would like you to go back, take this back and review it over the next month. In the October MAC, we would love to hear the feedback that the MAC committee has to our proposals. And you could share it live in that meeting and go through it, or you could, as a committee, present that to Sharon in advance and email her your feedback, and then we can walk through it at the next MAC meeting. What we would like to do is propose that in November, we actually hold a vote on the new bylaws as they are like presented today, and then put out for your comment and feedback and perhaps dialogue, a review of your proposal next month, and then have some dialogue there. And then in November, perhaps we could have a vote for that. What we would like to see, the mandated date of implementation for these were released in July of this year. We had 1 year to implement these changes. So we have up until July of 2025 to implement the updates to the MAC in the back, to our current MAC committee. And so we would propose that, you would also weigh in on a timeline for implementation. And you'll see what we have outlined here and sort of the framework that we have put forth. The other piece I'd like to call out as we look at what is currently the MAC, the MCAC, but will in the future be the Medicaid Advisory Committee, and a new committee that's proposed with this is called the Beneficiary Advisor Committee. So we would also like to request a second thing, and that is that in order to make up this new committee called the BAC, which is a subcommittee of the MAC, we would love to get some nominations from you. So if you are interested in participating in the future BAC, Beneficiary Advisory Committee, or you would like to nominate someone, we would also love to have you submit that to Sharon as well. So with that, we do have a 5-page document here that we have put together that look at our current MAC requirements per the bylaws. In the middle column, it is our Code of Federal Regulation changes or requirements, and then our proposed changes to the bylaws on the third column or on the far right side. We will be distributing these to you. They've probably already been distributed, but what we're going to highlight today are just those in yellow, just for the purpose of presentation. We won't go through everything, but we wanted to highlight the areas that we do believe have greater changes proposed, and also want to walk through sort of, these verbally with you in this meeting. So today, I think the one primary change we've already called out, Rachel mentioned it, but we're actually excited about this change. The Medical Care Advisory Committee is going to officially have a name change. And then from this committee, it's also going to launch a new committee. So what the final rule proposes and states is that the name change will actually be moving to the Medicaid Advisory Committee. So it's going to be the MAC. The other important piece of this is that there is a new committee that's shaped as a subcommittee of the MAC, but it is such a critical piece of the MAC, is the Beneficiary Advisory Council. And so the and we'll go into more details of what are the components of these different pieces down below. But just to highlight the continued emphasis we as a state program have had, and as our agency has, on really elevating member voice. Another important way that we even see our federal partners helping us do this through our MAC is through the Beneficiary Advisory Council. The changes to the bylaws that we do have here are proposed on the right-hand side. The next thing I'd like to call out is with regard to who the membership will be. So our current membership shows that the MAC will be comprised of at least 15, but not more than 19 members, and it defines who they are. So 49% of our membership today is comprised of provider representatives, and 51% have to be consumer representatives. One member is the executive director of the Department of Workforce Services or a designee. In the future, we see some changes coming, and what we see here is that the state actually has a little bit more flexibility in defining who these members are. And our proposal is that the MAC will be a number, MAC is composed that a number of members will not actually be changing. We would propose that it stays the same. However, 5 members of the MAC, sorry, there's a typo there, need to serve on the back. So what we see in the future is that 5 back members need to serve on the MAC. Or conversely, 5 members of the MAC need to also serve on the back. And you'll see why this is. The role of the back is it meets on a different cadence, but it needs to inform the MAC. And so the back will be comprised. And so if you look specifically at the back members, these are members who will be at least 7, but no more than 15 members. The back shall be composed of individuals who are currently or have been Medicaid beneficiaries, and also individuals with direct experience supporting Medicaid beneficiaries. So this would comprise of family members who are paid or unpaid caregivers of those enrolled in Medicaid. So those are the constituents we're looking for in the back. And then of those, 5 of those also need to be enrolled in the MAC as well. Okay, Sharon, if you could just slide down just a little bit. Okay, here's another change we've are introducing, which is meeting frequency. Currently, our MAC bylaws state that they need to meet a minimum of 6 times a year unless otherwise determined by the MAC Executive Committee. All these meetings are open to the public unless they've been designated as closed door. But as you know, our meetings are held open, and honestly today on a much more frequent cadence. So if you look at what we are proposing, first of all, is that there would actually be no changes to our current bylaws, that we will meet at least 6 times a year going forward for the MAC, and that they will continue to be open to the public. The change introduced with the back would be that the back would meet at least once per quarter ahead of the MAC meeting. And this fulfills our federal requirements so that the cadence would line up so that the back would meet quarterly, and that would occur before the time that the MAC met so that the back could report into the MAC. Now, one important difference with back meetings is that these do not need to be open to the public. So we would propose that these are actually private meetings. They are not open to the public unless the back chair and the vice chair determine that a public meeting is needed. However, our recommendation in our proposal would be that that the bylaws would state it here, is that they would by default not be open to the public. We will have meeting minutes posted for both the MAC and the back, and the back members can opt to not have their name on the meeting minutes and on the membership list if they desired to be private, and that we would happily omit those as a proposal of the bylaws. We're also going to propose in our new bylaws that we actually alter the meeting cadence for how it's experienced today for the MAC. In order to balance the meeting frequency and also support members who may be attending both the MAC and the back, we are actually going to propose that we hold our MAC meetings less frequently. Our first pathway is that because Medicaid policy is released every other month, that we would propose that the MAC meetings be held on an every other month cadence. In addition to that, we recognize that there are meetings held around legislative session, as well as the funding request meetings that would put us at a perhaps more frequent meeting cadence on certain times. But if you can see here, we are backing off on the number of MAC meetings that we would propose in future bylaws to support a back meeting and individuals being able to represent in both. So we'd like you to look through what we've proposed and give us feedback on that, but recognizing that back members are also going to be MAC members. We wanted to be sensitive to that and not overburden with excessive number of meetings, but also understand too that we wanted to maintain a regular cadence of MAC meetings so that it did align with our legislative session, our funding request session, and the cadence of our policy releases on the Medicaid side. Okay, next item, and I think, oh, that might be it. I think this is it. There are different items in here that talk about the roles of the chair, the vice chair, reimbursement for attendance at these meetings and participation in them, and then reports and recommendations as well. We would invite you to review all of these and please give us feedback on it. Again, what we would propose again is that while we've gone through and reviewed what the CFR requires, we've compared it against our current bylaws and created some recommended changes to align with those requirements, but also to kind of align with where our bring our current bylaws up to speed as well. We'd love to get your feedback on that next meeting, and then would give an opportunity then to actually walk through those recommendations. If you'd like to present something or submit something prior to that meeting, please feel free to submit it to Sharon in advance, and we'll go ahead and put it on the list to walk through. But yeah, I'll take any questions you have on this now, or we look forward to your feedback next meeting. Again, just to summarize then, we would like to do a vote on the final bylaws in the month of November at that meeting. And then I guess I could just wrap up with what we're thinking. As an executive committee, and Rachel, I'd invite you to actually give your feedback here too, is we're open to implementing these new bylaws in January if the committee so proposes. And so as a department, I think with regard to our proposed changes and looking at when we could even bring in the membership to do the back, we know we don't have to implement the back until July of 2025. But as far as adopting the new bylaws, we can do it anytime before July 2025, but they must be in place by July of 2025. So we'd also love your feedback on time frame for implementing these bylaws, and just offer that we know that we've had some interest in the back already, but knowing that we'd like you to also weigh in on those, but our willingness to adopt as early as July 2025.
Yeah, and just to share my thoughts off just from thinking about this, since it was presented to me, my thoughts are I appreciate and understand the challenges of having back members also commit to MAC meetings, and overburdening them with meetings and frequency. I also recognize that many of our MAC meetings run over in time as well, and trying to balance making sure that we can get all the work done, we can hear everything that we need to hear in the amount of time, while also cutting down meetings. That was one of my first thoughts. So I don't know if that would call for possibly longer meetings every, like on a bi-monthly schedule, something like that. That was kind of mine. And Jen, I didn't share this with you at the time, but what I was also thinking is possibly trying to transition back into hybrid meetings at some point. I know we tried once and it was fun and a little bit interesting, but I think we can probably work to, iron out some of the issues there. I would be a big proponent of, trying to transition back into a hybrid meeting environment and that doesn't need to be in the bylaws. Obviously, it's kind of outside of that, but that would be something that I would probably push and recommend. But those are kind of my thoughts off the bat there. I just worry about being able to get everything done because we will start stacking more reporting out. You know what I mean? I know we get these policy changes every other month, but there's other things in between there too. The back will take off some of the, consumer facing stuff, but at the same time, they're going to have to report to us. So those are my thoughts right now.
That's great. Thank you. Yeah, we look forward to the feedback. So thanks for this. I think that's all for this item then. Thank you.
Awesome. Thank you, Jen. Just one thing in the chat, and this is about the chip pack. Chip pack meetings are held quarterly. Thank you, Greg. So Jen, just to confirm, there'd be no changes to the chip pack. That will stay the same.
That's correct.
Good to know. And that is a plug. So if you want to start, attending chip pack meetings, those are quarterly. And then next item is an eligibility enrollment update from Michelle Smith. So I'll hand it over to you, Michelle.
Yeah. Hi, Rachel. Hi, everybody. Sharon, if I can, thank you. We'll take over. I am going to display the August enrollment report, and I'm also going to drop it into the chat for those of you who are not familiar of where to find that. It's available on our website. So these are August numbers. Total for August, right now we are currently at 341,202 individuals, which is slightly down from July, which was at 345,173. If you move over to the data table here, I was looking at each individual coverage group. There has been a slight decline overall in most coverage groups. There are just a couple outliers where child medically needy, pregnant women, where there was an increase. I do want to mention, I know most of you are aware of this and we've talked about it in the past. There's still individuals that will be reinstated in the month of August. People do have that 3-month reconsideration period at review to provide the paperwork that was missing or that review form. So there will be people that come back and get reinstated into coverage into these groups over a period of time. So just keep that in mind as you're looking through these numbers. I do want to bring up another graph, but before I do, I'll just pause there. There's really nothing significant to really point out or touch on with this. So I'll just pause and ask right here before I move to my next table that I will show you to see if there's any questions.
The pregnancy increase in that group, that's likely due to postpartum extension, right? Because now that that's in effect, so it's people are staying on longer. So we'll hit basically in that group kind of the new normal number once we get to maybe 1 year out from that policy being in effect, something like that. And then that will probably be the new normal number that, I guess pregnancy is always going to relate to probably more like birth rate, but generally speaking, we'll see that.
Yeah, no, absolutely. Thanks for pointing that out, Rachel. That's definitely factored into the increase in enrollment, which is great. So, yeah. Okay. Any other questions on the enrollment report?
Yeah, I have one, Michelle. I'm wondering if it's possible, and I don't know if this would be helpful, but I'm just wondering, I'm so curious about what it looked like in 2019, for example, or even like I'd be curious about like 2019 compared to like now, but like the same month. Just because we should have a lot more because of expansion, right? But just like also like those COVID years like threw us off so much that I'm just curious, like if there's a way to track it.
Yeah.
Does that make sense?
Yeah, no, absolutely. That's a great question. And I'm hoping that I am going to answer this right. And if I don't, just let me know, Steph. But if you can see on the table here, this does go back to pre-2000. So actually I'm hovering over right now, August of 2019, and total member count is 311,634. So, and then if I go back again, for those of you who may have forgot, we're currently at 341,202. So it is up from August of 2019 to present. So, and that's what's kind of nice about this. It's really is an interactive graph, and you can kind of play around and look at the different coverage groups. If you want to, focus on one group specifically, you can hover over, you can go over here to the graph here and, just get rid of all of the covered groups and just look at one, because there are a lot of rows here. It does get really hard to kind of focus in on one, but it is interactive and you can look at that. So I don't know if that answered that for you, Steph, or not, but if you have more questions, let me know.
Yeah. Could you help me understand? Like, I can't remember. It's been a long time, but I thought that like the prediction was that Medicaid expansion was going to expand to, I believe, somewhere between 100 and 150,000 new members. And so I am just curious, what is the explanation other than that we struggle to enroll eligible individuals for having such a small increase from that 2019 to today, I guess, when we compare it like that?
Yeah, I don't know. That's a really, really great question. I'm going to phone a friend here and look for Brian or Jen to maybe weigh in on that question. That's a really good question. So I don't know if.
Yeah, I don't have good hypotheses, Stephanie. So I think we're at about 80,000 or something. I would also just point out that economic conditions change as well. So, I mean, our economic condition recently is different than 2019, and that will have influences on the number of people eligible. So, I mean, that could be a factor, but I mean, in some respects, the pandemic did just change a lot of things, and so I don't know. I don't know if those estimates are as reliable or a benchmark anymore, but I don't have a good hypothesis for that.
Do you know what went into making that assumption back in 2019, 2018, 2019, and just like, I guess like what economic assumptions or things like that? Because I don't really know all that stuff, but like it doesn't, I guess like what I would just be curious, like, are there actually significant economic indicators that have been super different? I mean, it just seems like Utah has always boasted having one of the best economies in the country. And I believe that that was something that politicians said back in 2019 too. So I guess I'm just like, is it that different, or is it like, you know, I mean, I have my own hypothesis and I'm sure we all know what it is, but like, I guess I'm just trying to understand, like, are there other hypotheses, especially that might be more objective than like mine, to understand like what is happening? Because it does seem like, I mean, I think we would all assume that it would be quite a bit more. But also I haven't looked at like each population group and like what contributes to that number. So like, is it that there's less kids on, like, I don't know, but it just seems like that. I don't know. I guess like, have y'all done that? Like, have y'all like looked at each population group and program and like compared to like 2019 to today to like see what those differences are when we like try to, I guess, like look back from pre-COVID to now?
Yeah, a little bit actually. It is a good question. One thing we actually are going to be talking about in the director's report is some American Community Survey data that was just published last week, and it is more of an objective look. And they do a number of things. American Community Survey monitors more than just economic things, but they do track individuals at certain poverty levels. They track insurance status among children, adults, aged population. So, I mean, a couple of data points, for example, the 2019 uninsured rate among Utah adults 19 to 64 was about 12.1%. In 2023, it's about 10.1%. So there has been a statistically significant drop there. But other items, I mean, I mentioned economic factors. I just this week compared, for example, children, because children would not be affected by adult expansion, obviously, but American Community Survey also publishes the amount of children living in households that are lower than 200% of FPL, which is our CHIP benchmark. And between 2019 and 2023, the number of children living in households at that income level has decreased by about 28,000. So that would represent kind of a 10% decrease almost from the number of children just by economic factors alone that would qualify for Medicaid or CHIP. And I can share those resources. It's through U.S. Census Bureau. It's the annual American Community Survey.
Awesome. Thank you. Yeah, that is helpful. That is helpful. We still are above the nationwide uninsured rate, correct?
I do not know that off the top of my head. I think what it showed in 2023, we were at 8%. I don't know what the national is. That's just the statewide.
Gotcha. Okay. Well, that's helpful. Yeah, I do think, I guess I would just be interested in understanding, like, if there is still like a population group that is, being like that is uninsured, that is eligible, and just understanding more about like what that population group is experiencing. I mean, I talk to those people, and so I feel like they definitely exist. And so I just, am always going to be kind of encouraging us to like make sure that they don't slip through the cracks, and that we're getting like, eligible applicants enrolled in a better way. Because I think they are, people do seem to drop off, or just, stop the process when they're not getting their verification submitted and things like that. And so I guess we'll just continue to make improvements with notices and hope that we see some improvements with that along the way.
Yeah, thank you, Stephanie.
Yeah, no, thanks for that. And are there any other questions on enrollment? I guess I'll pause real quick and ask. Okay, if not, I do want to just kind of remind you all, we did continue our eligibility data dashboard with outcomes. And for those of you who don't know where to find that, you go to our Medicaid homepage, and if you go to the administration dropdown and go to administration home, you'll get this page right here. And if you scroll down, it's right here. You can click on eligibility data dashboard. We do still update this monthly. CMS did continue requiring states to report each month on review outcomes. So we do submit that still to CMS. And right here, you can see last month's report. We do continue to see an increase in our ex parte rates, which we're very excited about. For those of you who may not know, who may be new to this information and may not know what ex parte means, that's when we can complete a review without requiring any member participation. We did automation for ex parte last September, and since then, we have seen quite a bit of an increase in our ex parte rates. What this has also meant is that our procedural terminations has also decreased, which is also great news, and we're happy to see that decrease as well. So if you all want to look at this at any time, we do update it monthly. I'll drop that link in the chat as well for you guys to see. The other tabs are still available. I won't necessarily go into those in this meeting for the sake of time, but you guys are all welcome to go to this webpage and look around. And if you do have any questions, you're always welcome to reach out to me and I can help with any of those questions. So I will just stop there and hand it back over to you, Rachel.
Awesome. Thank you so much, Michelle. Any other questions for Michelle on the eligibility report or related to eligibility data? All right. If nothing else, I think we're going to move on to agenda item number 6. Handing it back to Director Schrocker for the director's report.
That's great. Thank you, Rachel. Just a couple updates we want to share with you regarding some policies that have been released in September and are and also some enhancements and some changes that are coming. First item we wanted to share was on private duty nursing. So what is private duty nursing? They're medically necessary skilled nursing services for eligible Medicaid members. And these are provided in the home. They are designed to help someone kind of transition out of an inpatient setting or an institutional setting and move into their home setting. Private duty nursing can be given in an acute phase right after a person has been in an inpatient setting, such as a hospital, and then longer term as well. So there's 2 different areas that this policy does cover. While this is not a new policy, we've been working on this policy now for a few years to make it more robust with regard to the number of hours that people could qualify for. And then also there's 2 components for private duty nursing. Is first of all, as you look at the medical necessity criteria, there has been a grid that has that one of our nurse reviewers will work through looking at an individual's condition when they submit a request for private duty nursing. And this grid will then yield, based off of what the person's needs are, yield a score. And we've been working over the last couple of years to really look at the policy that's included in that grid to make it much more robust. And so in 2023, we actually did receive funding to be able to move forward with making this sort of private duty nursing benefit and service more robust for individuals who qualified for it. Because it took some time to work through this grid, the first step of that implementation was to use our existing grid and actually just increase the score that people would get when they did qualify for services. By increasing the score, this increased the number of eligible hours a person could receive for the nursing services. Just this month in September, we were able to release a new grid, which is hyperlinked here in this document, but it is also available. It came through our Medicaid information bulletin this month as well. It also should be on our resources tabs, our Medicaid resources tabs. But this is a much more comprehensive and sophisticated grid that does allow individuals who do qualify for private duty nursing to be considered off of multiple more criteria. Our staff worked a long time on this, used other states as comparisons, and then did have quite a bit of rounds of stakeholder feedback on this before it was finalized. So this is active now, and it has been released, and hopeful that it does help provide necessary services to people who qualify for them for private duty nursing. The next thing I think we've mentioned to you in the past, but wanted to give you an update because it is now here. And this is a sort of a refresh, but an enhanced look, and which is one of several stages that we intend to implement for our EPSDT policy. Or should I say the benefit? The early periodic screening, diagnostic, and treatment is a mandated benefit that is available to individuals on the Medicaid program from birth up to their 21st birthday. And this does a couple of things. Number one, it is a pathway for services such as preventive services and screenings, but it is also a pathway for individuals to access medically necessary services that may go beyond the traditional Medicaid benefit. Some important examples of EPSDT policy, the benefit in play, for example, would be an individual who may need, for example, occupational therapy or physical therapy services that may exceed the allocated benefit amount. Under the EPSDT benefit, what would happen is if the individual did exceed this, they could submit a request based off of medical necessity. Our medical provider, our medical director could review this request and authorize additional OT or PT visits for this child or individual. So what we're doing with this, first of all, is that we have, first of all, released a new manual that will be posted to our website this month. There have been several aspects of the manual that have been enhanced. First of all, what we found is, and just to say that our policy has always been available for EPSDT, but the transparency and perhaps visibility of this policy may not have been as apparent. We've had a website, but we're going to work on our manual and then bring forth a more robust website to make it more transparent for Medicaid providers as well as Medicaid members. So in our policy manual that's released this month, we're going to see different things where you're going to see in better alignment with CMS published resources and some of the best practice recommendations that they have put forth. We've also linked this manual with other manuals to call out EPSDT services in other Medicaid provider manuals, such as our mental health manual and other resources that we have. It does also kind of talk about additional resources, and so that it's a more useful resource for our providers. What we're looking for in the future, and so we have the manual that's published now, but I mentioned our website and resources documents. So first of all, our website will be going through a refresh. Our hope with our website is that it is a more useful landing page for both provider tab and a member tab that does serve as a resource for people to understand what this benefit is, and then also be embedded with links on how you can request EPSDT services from the provider view as well as the member view. We're also going to be developing a member flyer that will be useful for members in helping them be aware of this benefit and their rights and being able to access Medicaid member services through this website or through this benefit as well. We know that CMS is releasing guidance to states later this month on our EPSDT benefit. So we will also await CMS guidance and make sure that we are aligning with best practices as laid out in that guidance document as well. Any questions on our policy updates? Okay. Then Brian already touched on, oh, go ahead, Thais.
Hey, Jennifer. Thanks
Hi.
so much. This is really exciting. I was just wondering if you would be working with community organizations on spreading the word on materials. And I don't know if you had thought about having the flyers and materials in other languages as well.
Yeah, that's great. I think we haven't developed these materials yet, but we absolutely will make them available in other languages as we have with some of our other resources as well. We would love to post these to our website, and we can print them for free and distribute them like we did with some of our other member-facing materials. And that's just a request. I think you may be familiar with how to do that, but we will also be making them available when Medicaid is at community events. We will bring them to our community events and make them a piece of what we will hand out to members. But I think it's a great suggestion, and we would love to partner with you and other community-based organizations on spreading the word and making this a more ready, something that's readily available for people to understand and also access when needed.
Great. Thanks so much, Jennifer. Happy to support any way we can.
Awesome. Thank you. Okay, wanted to close with one last item that Brian already touched on with some of Stephanie's questions around, Medicaid enrollment, but this specifically looks at our uninsured rates in our state. And wanted to bring this to you. We've gotten questions recently post unwinding, and certainly this survey material that has been released just this past week from the American Community Survey does give us a lens into where we are in our state, but also nationally. And I'm going to pass it back to Brian to really walk through what this summary of the ACS does share about the state of Utah and where we are. I know this doesn't answer all of our questions, but at least it has been our benchmark for Utah's uninsured rates in the past. So we were thankful that it was released now so we could bring it to you today at this meeting. So go ahead, Brian, if you'd like just to walk through what this data shares about Utah and its uninsured rate.
Yeah, thank you. And it is a bit of a mixed picture in terms of like this isn't purely post unwinding experience. It's 2023, so there were some months of the continuous eligibility experience as well as some unwinding experience. But as I mentioned, we are at about 8% uninsured. That is essentially unchanged from 2022. The long trend is still down, but I don't want to give the impression that uninsured is a positive by any means. I think one comment you had made earlier, Stephanie, was that individuals do exist out there, and we absolutely know that that fall through the cracks. So I'm not saying by any means there's an acceptable uninsured rate. We hope to play our part in reducing that as much as possible. The American Community Survey does also track individuals below 138% of the federal poverty level, which is a range under which a lot of individuals are eligible. And that is at about 15.7% at a point estimate level. So there's margins of error on this. They can't sample everyone, so they put margins of error around it. It's not a statistically significant difference from 2022, but that point estimate is higher than 2022. It was at 13.7%. So I know that's I'm getting a little bit wonky with statistics. I hope I'm still catching the audience, but there are also additional breakdowns available that that we could go into, or perhaps have a further discussion on. So yeah, Stephanie, go ahead.
Yeah, so I guess thank you for this. So if I hear it right, you're twice as likely to be uninsured if you fall within the income bracket that deems you to be Medicaid eligible than just like your average Utah. Like your average Utah, like, right, is like 8%. So that's like the whole population. But like within this specific income bracket, it's double that. So you're twice as likely to be uninsured if you fall within the income bracket that is Medicaid eligible.
I think what you said is correct. Yes.
So that's just like very much like not surprising, but like that is like, I don't understand that. Like I don't understand how we have a higher uninsured rate for the people that are supposed to be eligible for Medicaid. And I just like we knocked doors, we like collected votes, we taxed our people to close that gap, and you're twice as likely than like, I mean, these are my neighbors, you know, like their lives are a hot mess and they're good people. And it's like, it's just really frustrating. It's like really sad. And anyway, we have to figure out like what we're doing wrong. I don't understand how I don't know. I just like that to me is, you would think the opposite if like in like a perfect policy world where it's like, there's these people that are not eligible for a program and that's why they're uninsured, right? Like they can't afford the marketplace or whatever. And it's like that income bracket should be the lowest uninsured rate. And so I like, and again, in a perfect policy world. So I guess that's just, you know, disappointing. And so I'm glad we know, but dang, it sucks, you know.
Very good point, Stephanie. Yeah.
And Jennifer Marchant, I think has a question or comment.
Yes. Can you hear me?
Yes.
Yes. What Stephanie's talking about is so important. I know back in 2018 when a bunch of advocates were trying to get Medicaid expansion on the ballot and the work everyone went to and the decades worth of work that went into, because with what Stephanie does and what I have done is trying to reach the uninsured population to help them. I mean, the uninsured population who needs healthcare to survive, to improve their functioning so that they can hold a job. So they're not experiencing these gaps in healthcare. I mean, it makes such a difference. It makes a difference between somebody getting the treatment and the meds they need and then, or not, and then they're taking a walk on the freeway, not what's the word I'm looking for? Because the meds help them with their thought processes and like, okay, you need to walk on the sidewalk and not the street. And then people like Stephanie and myself and counselors, social workers are constantly scrambling to put out one fire after another. And it's just, when is this endless tug of war? I mean, we're exhausted. And I can't, and so are the people who need treatment.
Yeah, this is like, I mean, I have some guesses as to why this may exist, and I don't know if it has to do, you know, with churn and people falling off and coming back onto the program. I mean, I think there's some people that are just never reached. I still think there are probably a lot of people that don't know that they're eligible for expansion because of the timing of when full expansion came into effect, then the continuous coverage provision, then unwinding. I mean, but some people, it does seem kind of, I feel like I use this word a lot, bonkers, to like have that be double in a population where that is Medicaid eligible. So I would certainly really love to see some more work done into this, and not just, you know, data analysis, but also like, you know, what are we going to do to address it. I mean, it's just, it's really shocking.
I know, and I've seen the people who get access to healthcare, the before and the after. When I would teach a class, they would come in looking like they were just discharged from a hospital. And then when they would be done with the class and have access to a doctor or a counselor, social worker, then they are able to be employed, maintain their relationships, have housing. They are functioning. They are happy. They have human dignity. And so anyway, thank you all. I'll leave it at that.
I'd also like to see kind of if any other states have this same weird phenomena. I don't think that's the word, but it's a word, going on as well. And if anyone has done it and corrected it and what their best practices were, because, you know, we're, as much as Utah is unique, it's not as unique as I think maybe some people think that they are. So I think it would be interesting. And that's something that, like, you know, I can look into in my free time as well. But seeing if there's any other states that kind of experience this same issue and if they have been able to correct it, what they've done. Because that would be, I think, valuable to know. Yeah.
Yeah, I think that's a good suggestion, Rachel, and a step that we can take from the department side is engage with even our neighboring states where I'm in frequent contact with my peers in others on the western area. And I think that's actually a really great question as we're all finishing this process of unwinding. We're now several months out. And this survey did just get released, like having some time to work through it with each other and talk about what they're seeing and strategies that we can even align on with regard to addressing some of these numbers. So I'm happy to report back on that. So I'll just take that one as an action step for next meeting.
Awesome. Thank you.
Yeah, one of the things that we've noticed at Holy Cross Ministries with my community health workers is that a lot of the times, kind of like the DWS system drops their applications in the middle of the process, and it's very difficult to get some sort of proof, because I don't know, it's just you go from one step to the next, and then all of a sudden it takes you back to the beginning. So there is no way of recording that, and I say that because we've been working also on childcare applications. So it's pretty much the same web page. And we've had so many problems with childcare applications. Fortunately, we were able to take screenshots of how the system was failing, but it was like 3 weeks of back and forth with DWS, with managers from DWS. They couldn't find the error in the system, and obviously for them to fix or to even know what we're talking about, they need to see it, but I say that because if you have a community member, especially us that we work with the immigrant population, they're never going to get, DWS is never going to get proof from them about what's going on with the web page, so it's I mean, like I said, it was like 3 weeks, maybe over 3 weeks of back and forth. And if it's left up to a community member to kind of advocate like that on her or his behalf, it's most likely not going to happen. It's because of agencies like us that, we're there just advocating, whatever it takes. That thankfully the DWS is able to fix the error, but it takes a long time, but I would say, that system lately has been giving us kind of, some problems that it's frustrated sometimes, and just to keep that in mind.
Yeah, I second that, Carlos, and it had me start thinking too about like a conversation that that we had, Jennifer, with your team, a while back, of just like, are there ways that we can maybe relook at the number of, like, are there ways we can increase what we allow self-attestation for? because anything we can do to decrease the verifications is going to allow eligible applicants to enroll better, because it's that area where it's not just are you eligible, but can you prove your eligibility? And I think that there's just so many stumbling blocks for that part of proving the eligibility. And while I want the program to be ran with integrity, like, I don't think it's being ran with it. Frankly, I don't think you can say it's being ran with integrity if you have that many people that are in the income bracket remaining uninsured. That is like just such. So I just think, like, if there's a way we can maybe revisit some of the conversations that we had and that list that we had talked to your team about and DWS about, because I know one of those things was like, are there some verifications that we can remove? Are there some things that we can have be moved to self-attestation, or just like other maybe creative things that we can figure out, like how to remove the burden from the applicant? Because, you know, I've shared this story before, but it's just like, I was going back through my paperwork, like it really for me was, the part of proving it, I was eligible, but just going through all the processes and then just, you know, anyway, just like not getting stuff turned in on time, but then thinking like, I didn't know I had more time. And so like, then I just wouldn't do it. Like, I would just be so frustrated that I would just like, I guess I'll just have to wait until I see my speech therapist again next month, or till my brother comes out to see me, or like, and so then I would just lose that time that I could have like had the extension that I didn't know about. And it took so long, and I was eligible the whole time. And I just think that is what is so frustrating, because, as Jennifer said, there's like, there's people that are not getting their medication and like their lives are falling apart because of that. And I just think there's a way we can try to figure out like that gap of like, it appears that this person's eligible, but technically the rules say we also have to do this, 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 and this. Like, analyzing that, I wish the audit would have like frankly like found some of that, because I know it's happening. Like, we're just like, people are falling through, and it's not because they don't meet the eligibility requirements. So I think maybe we could talk about what that looks like as well. Again, comparing it to other states, like, are we asking for too much? Are we like doing things that like other states aren't doing?
Yeah, we'd be happy to bring that back. And there are other things we can talk about through the executive committee's meeting to look at, areas of our media campaign and highlight the work we did across 2024. I mean, want to keep hearing your input, of course, but we can share what we're doing with regard to the E14 flexibilities. Many of these have made differences, many of them will be permanent, right? Like, those can become permanent things. But it's maybe good to do an inventory of where we're at and get your feedback on some, other initiatives that we're also working on, right? So I hear your frustration and recognize where you're coming from. It's ours as well. And I think that's one of the things that we were concerned about with unwinding, right? So let's talk about it through the executive committee, and then we as a department can bring back things. We'd also like to hear your ideas on other ways that we can address the concerns that you're bringing up. Okay.
Any other, is that, Jen, is that the end of your presentation?
That was
Cool.
the end of the
Any
updates,
other
yeah.
questions or
Thank you.
comments on this portion of the agenda? Okay, seeing none, I think the next and last agenda item is committee member updates. So this is time for any updates from committee members. I'm not sure if we have any today, but I will silence myself to see if we do have any. Yeah, Dr. Britton, go for it.
Yes. So I work with the team that does trach vent clinics for kids that are in the community on ventilators. This is separate from the other issue that we talked about earlier about trach vents, but because of the Respironics stopping their trilogy vents, we're going to probably have an influx of kids going to the ICUs for vent changes, because our protocol is you have to be in an ICU to make a vent change. So it's going to probably be an uptick in some ICU admissions once we're not in respiratory viral season, which sadly seems to last 12 months a year. So we're working on that, trying to work with systems to try to decrease that stress, because these are all mostly kids on Medicaid. Just we'll keep you guys updated if there are barriers. The hard part is that our skilled nursing and our LTACs are full. Our NICUs are full. Our CICUs and PICUs share the same bed space, and they're pretty full. And so it'll be a big stress doing this transition, but we're going to try to make it as low impact as it can be, and just to regret the fact that it's going to be a 72-hour, cost for a lot of these kids going in. But grateful that Medicaid helps us keep these kids in the community on ventilators, so they don't have to be in the ICUs all the time. Some states, you're in an ICU the whole time you're ventilated, and that can be 3 to 4 years for some of the preterm kids, or forever for some of our kids with chronic conditions. So we'll keep you guys updated, and if there's anything we can help with. Thanks.
Thank you. Any other questions or comments? Updates? Hearing and seeing none. Remind me, Sharon, do we do a motion to adjourn? I actually don't remember. Or do we just adjourn? Does anyone else remember? I don't remember. Be just careful. I'll take a motion to adjourn so I don't break any rules on my first meeting as chair.
Move to adjourn.
Anyone want to second that?
Yeah, I second that. Thank you, Rachel.
Awesome. Yeah, okay. Meeting adjourned. Our next meeting is in October. I'll see you all then. Thank you, everyone, for your time.
Thanks, everyone.
Thanks.
Thank you.